This is part 1 of kidney function assessment, that's about urine analysis. Urine analysis is the simplest test that can provide useful information regarding the basic functional status of the kidneys. The most reproducible urine specimen is that obtained upon awakening from sleep, because it is not influenced as much by excessive fluid and the protein intake. During collection, a clean catch midstream is preferred. If that's not possible, suprapubic aspiration or catheter is the best option. Urine should be examined fresh, preferably within 1 hour of voiding. If delay is anticipated, it can be stored at 4 degrees Celsius in the refrigerator, adding a few drops of acetic acid. Typical urine analysis character of 3 aspects of urine: physical, chemical, and microscopic. Physical character is about color, clarity, specific gravity, and osmolality. Chemical character is about pH, glucose, protein, blood ketones, urobilinogen, conjugated bilirubin, leukocyte stress, and nitrates. Microscopic includes RBC, WBC, tubular cysts, organisms, and crystals. Normal urine is clear. It is colorless to clear yellow to amber, but most common abnormal color observed in clinical practice is red to brown urine. Hematuria is the cause if only the sediment is red in color and has RBC with supernam being clear. The other urine color include white, which tells us the presence of phosphaturia, pyuria, or chyluria. Brown or black urine is a sign of myoglobinuria, metamoglobinuria, and alkaptonuria. Green is a sign of drugs such as amitriptyline, propofol, pseudomonas infection, and the like. Blue is a sign of methylene blue. Brown urine can be due to drugs such as chloroquine, nitrofurantoin. Pink is due to uric acid crystalluria. Orange can be due to drugs such as anti-TB and anticoagulant. Cloudy can be from crystal forming on standing, or phosphate crystal from alkali urine, uric acid crystals from in acidic urine. The odor is also important. Sweet or fruit odor is a sign of ketone. Maple syrup is a sign of maple syrup urine disease. Musty or mousy odor is due to phenylketonuria. Sweetie feet is due to isovaleric or glutaric acidemia or excess butyric or hexonic acid. A measure of urinary concentration, which is called specific gravity, is a weight of the solution compared with that of an equal volume of distilled water. When we compare a weight of the solution compared with that of an equal volume of distilled water, we are measuring specific gravity. In this case, it is about urinary concentration. Normal range is between 1.01 to 1.013. A low specific gravity is seen in polydipsia and diabetes insipidus, and in conditions affecting renal concentrating ability. A high specific gravity is seen with inadequate fluid intake or dehydration. Osmolality is determined from the concentration of solids in the urine, which includes primarily salts and urea. Osmolality might be decreased in renal insufficiency as well as in state of central and nephrogenic diabetes insipidus. However, osmolality is not routinely measured. In most situations, osmolality can be approximated from specific gravity according to the formula. Osmolality is equal to specific gravity minus 1 times 40,000. The normal range is from 40 to 1,500 milliosmol per liter. The other is pH. Normal urine pH is from 4.5 to 7. It varies with food intake, lower pH with high protein diet. Early morning pH is less than 5.5, which is an indicator of good acidification. pH greater than 7 may suggest defective acidification in the absence of infection and prolonged storage. Deep stick can read pH 5 to 9. They are not accurate when pH is less than 5.5 or greater than 7.5. Alkaline urine in the presence of UTI suggests urea splitting organisms such as protease. The other component of urine analysis is protein. This primarily detects albumin, and the test is highly specific but not very sensitive for the detection of proteinuria. Protein excretion must be more than 100 mg per day to be detected. Normally, nil or trace on dipstick. 24-hour urine protein less than 4 mg per meter square per hour. And it is also less than 0.2 mg per milligram. Nephrotic range proteinuria is said to be there if it is greater than 2 mg per milligram. False positive in alkaline urine, concentrated urine, pyuria, and bacteriuria. False negative in diluted urine, low molecular weight proteinuria. If urine dipstick says +1, it shows the proteinuria is around 30 mg per dl, +2 shows proteinuria of 100 mg per dl, +3 is 300 mg per dl, +4 is greater than 500 mg per dl. Two screening tests are initially used to quantitatively assess urine protein excretion. That is urinary dipstick and the urine total protein assay. Extremes of urine dilution and the concentration can significantly affect protein concentration in urine. Albuminuria is said to present if it is less than 30 mg per dl, it is normal. 30 to 300 is moderately increased, and greater than 300 is severely increased. With GFR, to screen for and classify renal disease severity. Albumin together with larger protein like immunoglobulin G as a measure of glomerular selectivity in glomerular disease. The next is blood. The dipstick method detects heme, either RBC, hemoglobin, or myoglobin. Reagent strips for blood rely on the peroxidase activity of hemoglobin to catalyze an organic peroxide with subsequent oxidation of an indicator day. False positive occurs with oxidizing agent, alkaline urine, presence of bacteriuria, and excess ascorbic acid. If blood is greater than 5 in centrifuged and greater than 3 in uncentrifuged urine, we call it hematuria. Dipstick is highly sensitive, and the negative dipstick reliability excludes hematuria. If dipstick is positive and the microscope is negative, that is not RBC, that is myoglobinuria and hemoglobinuria. Normal urine has few, if any, intact red cell generally. Urine microscope should be performed whenever dipstick test is positive. Because as we have said, if dipstick is positive and the microscope is negative, that is myoglobinuria and hemoglobinuria. If both of them are positive, it shows RBC. The next is glucose. Glucosuria occurs due to inability of the kidney to reabsorb filtered glucose in the proximal tubule despite normal plasma levels. That is renal glucosuria, or due to urinary spillage because of abnormally high plasma concentration. Glucose in urine reacts with oxygen in the presence of glucose oxidase impregnated on the test strip. The renal threshold for reabsorption is a plasma concentration of 180 mg per dl. Presence of hypochlorite ions or other oxidants may give a false positive reaction, while large amount of ascorbic acid, ketones, or tetracycline may result in a false negative reaction. Based on a reaction of acetoacetate and acetone with nitroprusside on the strip, we measure ketones. Urine ketone measurement does not detect beta-hydroxybutyrate, it only detects acetoacetate. This positive is ketonemia, that is due to prolonged fasting, decay, methylmalonic acidemia, propionic acidemia, and the like. False positive is ascorbic acid, captopril, acidic and concentrated urine, and phenylketonuria. Nitrite reduction test can be used as a screening test for UTI. Nitrite splitting bacteria split nitrites in urine into nitrates, which react with aromatic amine on the test strip. The test is positive with UTI caused by coliformis. A negative test does not reliably rule out infection. Negative test in the presence of UTI is usually due to non-nitrite splitting organisms, mainly gram-positives. Leukocyte stress test depends on the stress activity of granulocytes. This is an enzyme produced by granulocytes. A positive test should be followed by microscopic examination of a urine. False positive test is seen in non-infectious inflammatory states, whereas false negative tests occur with excess proteins, ketones, and drugs. A negative test in the absence of symptoms rules out UTI. In alkaline urine, test would be positive despite negative microscope, as WBC would be least. Hence, both microscopic and the leukocyte stress tests are to be done when investigating UTI. The correlation is, if it is +1, it shows 10 to 25 WBC. If it is +2, it is more than 75, and if it is +3, it is greater than 500 WBC per millimeter cube. So, test would be positive despite negative microscope, as WBC would be least. So, both microscope and the leukocyte stress tests are to be done when investigating UTI. Less sensitive in presence of glucose or concentrated urine in newborns. Let's go from the deep stick to the microscopic. The microscopic test, or examining the sediment, the first is cells. From cells, RBC and the WBC are one of them. Hematuria in the presence of more than 5 RBC per high power field in a centrifuged specimen of urine, and dysmorphic RBC shows glomerular and it is normal. That is extrarenal lesion. Leukocyte, that is leukocyturia, is defined as greater than 5 leukocytes per high power field in centrifuged urine or greater than 10 in uncentrifuged urine. Epithelial cells appear in the urine after being shed from anywhere within the genitourinary tract. There are 3 types: renal tubular cells, which is round, rectangular, polygonal, or columnar; urothelial cells, which can be superficial or deep; and squamous cells. This is a constant finding: abundant cytoplasm, few granules, small central nucleus, and folded edge. Tubular cell casts are seen in nephrotic syndrome, acute tubular necrosis, and pyelonephritis. Superficial urothelial cells seen in mild disease of urinary tract. Deep urothelial cells are seen in moderate or severe disease of the urinary tract, such as urolithiasis and hydronephrosis. Squamous cells are normally present or as contamination from vaginal discharge. The next is cast. Casts are produced by the aggregation of TAM horseval protein with cells or cellular debris in the renal tubule. Hyaline cast, which is non-specific, and the granular cast, which is also non-specific. Hyaline cast can be caused by concentrated normal urine, and the granular cast can be caused by exercise, acute tubular necrosis, and tubular interstitial disease, and also glomerulonephritis. RBC cast is hallmark of glomerulonephritis. This is less frequently with tubulointerstitial disease, and the presence of even one RBC cast is suggestive of glomerular pathology. WBC cast is due to tubulointerstitial disease, acute pyelonephritis, and lupus nephritis. Mixed cast is a combination of 2 or more casts. This is seen commonly in tubulointerstitial disease. Fatty casts is seen in nephrotic syndrome and also associated with heavy proteinuria. Waxy casts are broader, and the chronic parenchymal disease can cause waxy casts. Epithelial casts are rarest of casts to be reported. They are usually seen in acute tubular necrosis, viral disease, heavy metal poisoning, and the like. They may be one of the indicators of acute allograft rejection when detected in significant numbers during early post-transplant period. The next is crystals. Crystals are not always pathological. They are formed due to supersaturation of urine. This is influenced by metabolic abnormalities, diet, delay in analysis, temperature, and pH changes. Crystals are seen in large numbers and in aggregates form in stone formation. Cysteine, tyrosine, leucine, and cholesterol crystals are always pathological. Crystals in acidic urine can be due to uric acid, amorphous urates, calcium oxalates, cysteine, leucine, and tyrosine. Crystal in alkaline urine can be from calcium phosphate, triple phosphate, and amorphous phosphate. The final component of microscopy is microorganisms. Bacteria is frequently seen in sediments, which is often due to contamination. This is significant if leukocytes are also present. Fungus is commonly seen in Desertis candida, which is normal flora. Trichomonas vaginalis is often a contaminant. This is a part 1 of renal function assessment. We'll discuss glomerular function assessment in the next part. Thank you for watching.